All right, good afternoon. I know there's not a lot of people in here yet. Hopefully they'll come in with their lunches. I want to thank you all for attending this year's scientific abstract session of the AOCA 2022 Annual Convention and Conclave Vapor. We have 2 scientific abstracts to present and 8 complex cases to present. I'm going to introduce each author prior to their presentation. The first one I'll stay over here, and then I'm going to stay over there for the rest of them. Each presentation should be about 7 minutes long, with 3 minutes for audience questions. These questions are going to be fielded by our 4 moderators, Dr. Mario Gonzalez on the end, Dr. Tanya Schnell, then Dr. Jane Huffnagel, and myself, Suzanne Huffnagel. After each presentation, the audience will be asked to rate each presentation by scoring 3 questions. Now, how you do this is, if you've downloaded the mobile app, you click on this session, and each abstract is going to come up separately. Scroll down at the end of the abstract, you will see something that says, take the survey. You click on Take the Survey, the 3 questions will be there. They're going to be graded from 1 to 10, 1 being the lowest, 10 being the highest. The questions for scientific investigations will be slightly different than for the complex case presentations. The average of the audience's scores, then I will get, and I'm going to add that to our moderators' scores to help determine the top 2 authors of the complex case category and the top 1 in the scientific abstract category, since we only have 2 submissions in that category, and they will get monetary awards, which will be announced at the conclave tonight. The first group is going to be presented virtually with a recorded presentation, and then the author will be there for virtual questions from the audience, and then the last 4 will be presented in person. So let's give our attention to these authors. They've worked very hard on these presentations. The first abstract is a complex case entitled Unusually Low SaO2 Reading in the Setting of Obstetrical Regional Anesthesia. Will be presented virtually by Dr. Lauren Hamill, who comes from UPMC Lidditz, and I apologize if I make any problems with some of the names. I don't want to pronounce them wrong, but I apologize ahead of time. So let's give our attention to the first presenter.
Hello, everyone. My name is Lauren Hamill. I'm a 4th-year anesthesia resident, and today I'm going to be presenting a case that myself and Dr. Baihan Lee saw roughly a year and a half ago in our institution. This presentation is entitled Unusually Low SaO2 Reading in the Setting of Obstetrical Regional Anesthesia. At this time, I do not have any conflicts of interest to disclose. So a brief description about this case. We have a 42-year-old G1P2 female who presented to our labor and delivery unit for a rupture of membranes. She was at the time 35 weeks and 6 days, and she was being induced for preeclampsia with severe features. She had asked for an epidural for pain control, and as the resident on the case, I went over and completed a pre-procedure evaluation, which was only significant for a cough and sinusitis. This being about a year and a half ago or so, COVID was kind of rampant in our institution. And so she was tested prior to arrival, and she was negative. She was prepped and positioned for epidural placement. While this was occurring, nursing had mentioned to me that they were having difficulty obtaining readings on the pulse ox. They had tried her fingers on each hand. They had also even tried her feet, excuse me. They had reported readings as low as the mid-70s, up to the mid-80s. And this was unusual for them, and definitely unusual for me. but the patient was not unstable. She was very hemodynamically stable. Her blood pressures were normotensive. She was not tachycardic. Everything on her looked great. She was not dyspneic. She was tolerating labor, very well up until this point. And we made the decision to proceed forward with the epidural. It was placed without issue. While we were placing the epidural, I had asked for a remote monitor to be, brought into the room, and one that actually had like a plasmograph reading. Once she was comfortable, after the epidural was placed, as I mentioned, this portable monitor was brought into the room, and we actually used an ear probe and found that we got a SaO2 reading of about 82%. As I said, with a good waveform present. Immediately, we placed the patient on 4 liters of supplemental oxygen via face mask. We summoned the on-call obstetrician and midwife to the bedside, and they ordered a set of labs, repeat labs, as well as a repeat COVID, as well as flu and RSV swabs. They also ordered a CT scan of the chest in order to possibly rule out what they thought may have been a PE. At the time of all of these assessments, though, it's important to note that fetal heart rate was very stable throughout all of these events. The results of the tests, the labs were within normal limits. Her COVID, RSV, and flu swabs were negative. And additionally, the spiral CT was negative for pulmonary embolus. However, there were some cystic lesions that were present in all lung fields. And per the radiology read, it was concerning for either tuberous sclerosis or lymphangiomyomatosis. So the picture on the left here just shows, on the far left, it shows what normal lungs look like. And then they actually have a little detailed image here at the bottom. And then compare that to a lung that has lymphangiomyomatosis, where you see here on the side, they have all of these lung cysts. And even sometimes you can have a collapsed lung or a pneumothorax. And you can see here, all of these cysts are blocking all of the airways. And then here on the right is what the CT scan actually looks like. Our patients looked extremely similar to this, with just all of these cysts everywhere. And she had absolutely no idea that any of this was going on. She had never heard of the term lymphangiomyomatosis. And as I mentioned, no previous health history related to any lung or pulmonary issues at all. So what is lymphangiomyomatosis? It is an extremely rare lung disease that actually tends to affect women of childbearing age. It's caused by abnormal growth of smooth muscle cells in the lungs, as well as in the lymphatic system. And as I said, it can lead to these cysts in the lung, which can obstruct the airways. Patients may also develop growths in the kidney, and these are called angiolipomas. And many people don't even realize that they have lymphangiomyomatosis because these symptoms are similar to having asthma or having bronchitis. You may recall I mentioned that she had complained of a history of a cough and sinusitis. Could these have been the symptoms? We're really unsure. But again, she had absolutely no idea that this was an issue, because up until that point, she was essentially very healthy. She did proceed with a spontaneous vaginal delivery of her infant. She did very well with that. She had no issues throughout the labor, no issues through the delivery, no problems with dyspnea. During the delivery, she was she stayed in the hospital. Typically, our patients stay for 2 days. I believe she stayed for 3, just to get appropriate follow-up, and just to monitor her, because she did have some periods throughout the night of a little bit of dyspnea, and where her where her oxygen saturation, her levels would drop a little bit. But overall, she did very well with that. She was sent for a VEGF-D level, which was elevated, which is indicative of lymphangiomyomatosis. Additionally, there is no cure for this disease. However, there are several treatments that are available to both stabilize the disease and then also to prevent progression of the disease. Sirolimus is one of those medications. Putting patients on oxygen therapy is another treatment. Putting patients on inhaled medications, and then the ultimate treatment would be lung transplant if necessary. Additionally, more than 90% of patients are alive 10 or more years after diagnosis. So this is very encouraging for our patient, who now has 2 young children. And as I mentioned, she is continuing to follow up with pulmonary as needed. Thank you for allowing me to present my case. Please let me know if you have any questions. Thank you.
Hi, my name is Jeffrey Tsai. I'm one of the anesthesia residents at Larkin Community Hospital located in South Miami, Florida. I'm going to present my case report regarding to hypothesized systemic approaches to manage acute cardiac tympani during the pulmonary vein isolation and radiofrequency catheter ablation. My disclosure: I have neither conflict of interest nor financial engagement within relation to this program or this presentation. So my objectives includes to correlate the electrophysiological studies, abbreviated as EPS, which including the pulmonary vein isolation, abbreviated as PVI, and radiofrequency catheter ablation, abbreviated as RFCA. I want to correlate the EPS with the acute cardiac tympani, and then I will present my case presentation with the patient record. And at last, I'm going to discuss how to manage the acute cardiac tympani during EPS study. So basically, the EPS with or without RFCA are an essential component in diagnosis and therapeutic workup for drug refractory arrhythmia. And so EPS study, basically you are doing putting a percutaneous introducer catheter to record heart electrical activities to identify the source of the arrhythmia. In our case, we were trying to identify the source of AFib, atrial fibrillation, abbreviated as AFib. And also during the perioperative acute cardiac tympani, which can happen when you have a perforation during the PVI and RFCA. However, the incidence is low. Statistically, the incidence rate is between 0.6% to 1.3%. But of course, if the cardiac surgeon is proficient in skill and experience in acute management, the incidence rate will be lower than this number. And however, because the acute cardiac tympani is a very serious complication and require immediate percutaneous pericardiocentesis to prevent sudden cardiac death. Therefore, prompt management and diagnosis is actually important to give you good outcome. In our case, we have a 49-year-old lady with a past medical history of hypertension, transient ischemia attack, and paroxysmal AFib, presented with a recurrent palpitation, syncope, and also had a previous EPS study. After the previous EPS study, patient actually had wear a loop recorder to further diagnose with the six-signer syndrome. So this time, patient had undergone a second EPS with PVI and RFCA with us. Pre-workup, we did a transthoracic echocardiogram showing that patient's left ventricle ejection fraction was within normal range 60% with a mild tricuspid regurgitation and trace pericardial effusion. CT angiogram of the pulmonary vessel and aorta also showed no acute findings, including pulmonary embolism or aortic dissection or aortic aneurysm. Intraoperatively, we did a esophageal echocardiogram that's showing a diastolic volume reduction in the right heart and reconfirmed trace pericardial effusion. However, during the transeptal process, patient actually had a acute hypotension that actually refractory to any vasopressors or fluid resuscitation. And the cardiac surgeon suspect that due to patient previous EPS study, that might cause anatomical distortion with patient's current pre-existing big heart. Patient likely to suffer the transeptal puncture or mechanical injury to the pulmonary vein of the left atrium, and then start to accumulate blood into the pericardial sinus and likely become the reason that patient had refractory hypotension. And uniquely, this patient did not show any classic sign of Beck's triad, which including muffled heart sound, jugular venous distension, or hypotension. So basically, this patient only have 1 out of the 3 Beck's triad. And the reason why patient has the hypotension, once again, is because the cardiac tympana induce compression in the right heart and further decrease the venous return and ejection fraction. So that's why patient had the hypotension. So immediately we gave intravenous flow resuscitation with crystalloid, vasoactive, ionotrope, and blood transfusion. And the urgent percutaneous pericardiocentesis was able to drain out for 400 cc of blood from the pericardial sac. And after the pericardiocentesis, patient was stabilized and then sent into ICU for further monitoring. And patient actually was also inserted with a drainage tube. So over the next couple hours, patient was also draining 250 cc of the sanguineous fluid over the next 48 hours. So the ideal management for acute cardiac tympana during EPS with PVI and RFCA is that, first of all, the classic Beck's triad are actually not reliable, just like our case. Our case only showing the hypotension without the muffled heart sound or jugular venous distension. So we want to advocate that in order to manage acute cardiac tympana, we need prompt diagnosis with perioperative and intraoperative transthoracic echocardiogram and transesophageal echocardiogram. And the cardiac surgeon need to be proficient in skill to manage the emergent pericardiocentesis. And of course, we have to provide intravenous fluid resuscitation and positive ionotrope or blood transfusion as needed. And for EPS study, we always want to have a standby cardiac thoracic surgeon to perform a pericardial window to prevent further reoccurrence. Thank you for listening to my presentation, and these are my references. Thank you.
Hello, I am Matt White. I am a C3 resident. I'm at the University of Texas Medical Branch, UTMB, in Galveston, Texas. This is a medically challenging case I'm presenting. It happened when I was a CA1, but I am excited to be presenting it to you today. It's regarding a case of refractory bradycardia after a patient received dexmedetomidine. I have no conflicts of interest to disclose. At first in this presentation, I will be presenting the case and how we handled the case. And then I'll be talking some about the pharmacology of dexmedetomidine. I may call this Precedex just because it's easier to say, not that I'm trying to promote that brand or anything. And then I may discuss some management of bradycardia. Okay, so here's the patient. He's a 61-year-old. He's in the hospital because he has gangrene in his right foot. This is not the first time he's had an infection in his foot. He's kind of a frequent flyer. He's got some significant cardiac and vascular history. Underlined, you see there's sick sinus syndrome. Has had atrial fibrillation documented in the past. And he has had coronary stents placed for his coronary artery disease. Also, he has ESRD. This is his pre-op EKG. The computer read it as a junctional rhythm rate of 50. We plan to do general anesthesia for his below-the-knee amputation that was planned for him, and listed there are his preoperative vitals, nothing too concerning. The induction of anesthesia was unremarkable, and arterial was placed post-induction. I listed the estimated blood loss there just for your reference. It's pretty standard at our institution to call it 400 milliliters just because that's about how much is in the leg that's removed. It wasn't a particularly bloody amputation. And he was on a norepinephrine for a short time in the case. We didn't try phenylephrine or anything else. We just went straight to norepi. And it was never a high dose, so not really unexpected hypotension with general anesthesia. Also 75 mics of fentanyl given intraop, and got cisatracurium at the beginning of the case. We reversed that with neostigmine and glycopyrrolate. And then immediately post-op went to the PACU, stable condition. No issues there until he started having what was probably emergence delirium, getting agitated. The senior resident that was with me at the time, he gave him some fentanyl and dexmedetomidine, a total of 20 mics, charted as 2 doses. I'm not sure if it was how far apart those were spaced though. And then after those drugs were given, this is what we got. The patient gets profound bradycardia. His heart rate's in the 30s. He's stable though. We still feel his pulse. It's a strong pulse, not a 1 milligram of epi-push situation. So we start by giving him glycopyrrolate. That didn't do anything. We gave him atropine. That's not doing anything either. While we're getting those drugs ready, we're calling for an EKG, which is right here, the junctional rhythm rate of 35. Alright, so since the antimuscarinic drugs didn't work, we're thinking, what else should we try here? Well, we get some pads to put on them and try out transcutaneous pacing. Now this is pretty interesting because you could see the electrical activity on the EKG on the monitor, but if you look at the pulse oximeter, the pulse is still in the 30s. So the transcutaneous pacing isn't really working either. It's not capturing. So then we went to epinephrine infusion. This is the dose we started at, and things improved. It did capture, it increased the ventricular rate, as seen on EKG and on pulse oximetry. All right, so being on an epi drip, he needed to have critical care, so we got transferred to the surgical ICU at our institution. They were able to wean off the epinephrine infusion when his heart rate got up to the 50s, and it stayed in the 50s, which was his baseline after the epinephrine was weaned off. All right, so that's the case. I'll talk to you about dexmedetomidine, or Precedex, as many of you may know it. It's a alpha-2 agonist, not antagonist. If you remember from studying for step 1, however many years ago that was, the alpha-2 receptors are inhibitory, the opposite of what the alpha-1 receptors do. And these receptors are in multiple places. But the ones we're most interested are in the locus coeruleus, where inhibiting norepinephrine there, that's the one of the arousal centers in the brain. So inhibiting norepinephrine there, it causes sedation. And then acting at the receptors in the spinal cord, modulating pain signals, it creates analgesia. It has a slower onset and longer duration than other agents we're used to using, like fentanyl and propofol. All right, here's some of the uses. First used for sedation, that's what it's FDA approved for. Used in many different settings. And some of the advantages of using this over other drugs. Great for sedation in the ICU if you want to wean them off a ventilator, because it limited impact on respiratory drive for the same reason. Also great sedation for awake fiber optic intubations, because it won't depress the respiratory drive. It's great in the ICU because it promotes regular sleep patterns. I'd say it depends on the patient, but it can have less effects on hemodynamics than propofol. And that study, Ben 2001, demonstrated that. It has analgesic effects, as mentioned earlier. And so there's been some studies recently published in the ASA regarding opioid sparing or opioid free anesthesia. Okay, I think everyone that has used this is well aware that it can cause bradycardia. If you want to look it up in the literature, there's a reference for you. But the literature, there's not much saying like how much bradycardia, the magnitude of the bradycardia it causes, and not any studies talking about what to do about it when you get the bradycardia from it. One study that came out last year did talk about how severe the bradycardia was, but not very useful in this kind of setting, because most of those cases the bradycardia either happened because it happened immediately after the abdominal insufflation for laparoscopic cases, or one patient probably had local anesthetic systemic toxicity. So the bradycardia was probably more related to those, even though they happened to been given dexmedetomidine. So I thought this this case would be helpful for everyone, since that's not well described, and I haven't come across any other cases of this severe of bradycardia before, going from heart rate in the 50s or 60s to the 30s. This is a copy of the ACLS algorithm for bradycardia with a pulse. You'll see trying to identify an underlying cause. I think at the time we knew it was because of the dexmedetomidine. It also recommends getting a 12-lead EKG to see what rhythm they're in. And it shows some of the management there. It says that to try atropine. If atropine doesn't work, then try these other things: transcutaneous pacing, dopamine infusion. That we didn't try, but we did try the epinephrine, and that's what ended up working. Okay, to conclude, I don't want to give dexmedetomidine a bad reputation, because I actually love Precedex. I love using it on many cases, but I'm very careful with it in cardiac and vascular patients. So if you know this patient is at risk for having a bradyarrhythmia, especially if they have any sort of AV block or sick sinus syndrome, use it with caution or don't use it at all. When you do use it, you should be monitoring their heart rate and blood pressure closely. It should not be given in large doses as a rapid bolus. It needs to be administered slowly. And yeah, also in cases of other things that can cause bradycardia, try to control those other factors if you need to use dexmedetomidine. Here are my references, and I thank you again for letting me present this case to you. I'm happy I could tell you about this.
Hey everybody, my name is Matthew Cisan. I am a second-year medical student at the NYIT College of Osteopathic Medicine, and today I'll be presenting our research on an exploratory in vitro investigation on the relationship between NTEM and HEPTEM coagulation time ratios and heparin plasma concentrations in the obstetric patient. Now, to start, for this research effort, there were no financial disclosures or conflicts of interest. As an intro, venous thromboembolism is one of the leading causes of maternal morbidity and mortality, with unfractionated heparin often used as a mainstay agent for thromboprophylaxis. With the growing use of unfractionated heparin, the likelihood of obstetric patients presenting to the labor floor while on these medications for urgent or emergent delivery increases. As a result, it's important to understand the risk profiles of these patients, especially with regards to neuraxial procedures and overall anesthetic management. Now, while APTT and anti-10A tests exist, they're limited in their ability to predict relevant bleeding complications, and they're also highly variable depending on the assay used. Now, there exists point-of-care viscoelastic testing, such as rotational thromboelastometry, also known as ROTEM, which rapidly assesses patient blood profiles. Now, the way that ROTEM works is by analyzing a citrated blood sample for hemostatic qualities, assessing parameters such as clotting time, clot formation time, and maximum clot firmness. Now, there are different assays to test for various contributions of coagulation pathways and factors, and for this study, we explore the NTEM and HEPTEM assays specifically. In the NTEM assay, ellagic acid is used to activate coagulation, and as a result, analyzes the intrinsic pathway for factor deficiencies as well as the presence of heparin. Now, the HEPTEM assay is essentially that same NTEM assay with the addition of heparinase, and is used for analyzing heparinized blood samples. Now, as a result, we propose that the clotting time ratios of these two assays, NTEM and HEPTEM, could be a potential surrogate index of heparin concentrations and anti-10 activity, and that this is something that can be performed quickly and at the point of care. As a result, the objective of this study was to explore the association between varying plasma heparin concentrations and that NTEM-HEPTEM clotting time ratio using ROTEM in vitro in the obstetric patient. In terms of methods, this was an IRB approved single center prospective observational study with a population consisting of consenting non-laboring obstetric patients at term gestation with uncomplicated pregnancies and a specific hematocrit range. From these patients, venous blood samples were collected and the effects of increasing amounts of unfractionated heparin were analyzed using these NTEM and HEPTEM assays. Now, the amounts of unfractionated heparin range from 0 to 0.3 units per ml in intervals of 0.05. From this, the relationship between heparin concentration and the NTEM-HEPTEM coagulation time ratio was created. In addition, we also created a relationship between heparin concentration and APTT. In terms of results, 77 obstetric patient volunteers were included in the study with 11 patients for each of the heparin concentration groups. Again, that's at 0.0 to 0.3 heparin units per ml. Now, this first set of results pertains to the constructed nonlinear logistic model of the IHCT ratio as a function of in vitro heparin concentration, specifically in that blue. Now, in addition, we also compared our functional curves, the blue ones, to the smooth curves using the non-parametric loss method to visually inspect the model for fit, as seen in red. Now, in the graph, it was observed that as plasma heparin concentration increased, that IHCT ratio also increased. At a concentration of 0.05 units per ml, the IHCT ratio was less than or equal to 1.1 in about 82% of the samples. At a heparin concentration of 0.1 units per ml, the IHCT ratio ranged from 1.06 to 1.4, indicating a wider variability in heparin responsiveness between patient samples. When the plasma heparin concentration was 0.3, which was the highest heparin concentration studied, the IHCT ratio was significantly prolonged, ranging from 1.37 to 2.2. The mean absolute error of the model was 0.17 and increased as the heparin concentration increased. Now here we have the nonlinear model of the relationship between APTT and heparin concentration. In this model, the APTT increased as the plasma heparin concentration increased, and the APTT remained within the normal range, with plasma heparin concentrations ranging from 0 to 0.05. Now, to summarize between the two models, in most cases, the IHCT ratio also increased at heparin concentrations between 0.05 and 0.15 units per ml, whereas the APTT did not increase until concentrations at 0.1 units per ml. Now, in interpretation of these results, we can arrive at two general trends and takeaways. The first one is that if the IHCT ratio is low, e.g., for say less than 1.2 or 1.1, there's minimal to no unfractionated heparin in the blood. And the second one is that at higher ratios, generally over 1.2, there is an association with higher heparin concentrations. Now, although this study cannot directly inform clinicians about the safety of neuraxial procedures, it really gives insight into coagulation management, especially in non-laboring obstetric populations. While prior studies have examined this ratio in other patient populations, like cardiac surgical patients, this is the first study to our knowledge that analyzes this ratio within obstetric populations. Now, for this study, there were several limitations. There was no formal power analysis done, and the in vitro design lends to the necessity of further research on its generalizability to the in vivo environment. There were other limitations, including basic human error and when conducting the viscoelastic assays. And finally, this study only analyzed patients without hypercoagulable disorders. Now, in conclusion, although there is currently no clearly defined safe level heparin activity for a neuraxial procedure, our study really explores the utility of point-of-care NTEM-HEPTEM clotting time ratios in identifying when there's little to no activity of heparin present. Further research is needed to determine if this ratio can predict activity in vivo and how it can be applied to determine the safety of neuraxial procedures. These are our references, and thank you so much for listening and taking the time to hear out this presentation. And if you have any questions, please reach out. My name is Matthew Cison, and this is my email. Thanks again.
Hello, everyone. My name is Chandler Young. I'm a fourth-year medical student at William Carey University College of Osteopathic Medicine. I'm delighted to be here to present my case report of anesthesia used in an awake craniotomy. My co-author is Dr. Justin Bordelon. So a little bit of background about this case. A 72-year-old white male initially presents with mild headaches that have been progressively worsening over the past few months. The patient's wife became more concerned because of he had been progressively more forgetful and having more painful headaches, despite his history of dementia. So past medical history also includes hypertension, anxiety, type 2 diabetes mellitus, hyperlipidemia, atrial fibrillation, coronary artery disease, chronic kidney disease stage 2, and congestive heart failure. So he was referred to neurology and an MRI was ordered, which revealed a right posterior parietal occipital mass. And so discussing with the patient, the surgeon had decided that resection of the tumor was the best course of action. And so here's an image of that mass on the right posterior parietal occipital area. And so the treatment team decided to keep the patient awake to monitor the neurological function of the parietal occipital lobe as the mass was resected. And so specifically, the patient was asked throughout the surgery to move their left arm and to speak with their wife on the phone. From the anesthesiologist's point of interest, monitored anesthesia care was used with induction through propofol and dexmedetomidine through total IV anesthesia. And despite the challenge of maintaining sedation and consciousness, the mass was fully resected and the surgery was well tolerated by the patient. The patient had no complaints of pain during the procedure, and he tolerated it well. So some learning points from this case, the anesthesia team's role was to maintain enough consciousness to allow the patient to move and to speak and to make sure that they did not experience any pain throughout the procedure. The case reports current literature that a combination of propofol and dexmedetomidine for monitoring anesthesia care and local anesthetics such as bupivacaine for intra and postoperative pain control are adequate for awake craniotomies. And although conservative management such as this use of anesthesia may lead to potential consequences such as airway compromise and discomfort from the patient, this particular case highlights that the patient tolerated it well. And it helps support the notion that awake craniotomies are becoming a standard procedure in tumor resection with use of sedation. This concludes my case report. Thank you for your time. I appreciate all of your attention. And if you have any questions or concerns, please don't hesitate to reach out at my email right there. Thank you, and I hope you all have a lovely conference.
Hello, my name is Vish Tadagari, and I am a CA1 anesthesia resident at UPMC Lidditz in Lidditz, Pennsylvania. I'm going to be going over a case entitled Progression of Placental Abruption Occurring Soon After Placement of a Labor Epidural. So firstly, I have no conflicts of interest to disclose. So the objectives for this case are to review the mechanism of action of epidural analgesia, review signs and symptoms of placental abruption, and identify physiological changes due to epidural analgesia. So epidurals are commonly used in pregnant patients to control labor pain, and they're typically achieved using a combination of local anesthetics with opioids. The principal site of action is believed to be at the nerve root, and there is really a trifold mechanism of action. Basically, there is blunting of motor, sensory, and sympathetic blockade leading to pain relief. So there are a number of side effects associated with interaxial anesthesia in general. The one I want to focus on is hypotension. In regards to labor and lumbar epidurals, this is due to blockade of the T5 to L1 sympathetic fibers that control vasomotor tone. Blockade of these nerves results in systemic vasodilation, pulling blood and viscera on the lower extremities. That's further exaggerated in pregnant patients with increased blood flow to the uterus and pooling of blood in the reproductive organs. So placental abruption is defined as premature placental separation of the lining of the uterus. Patients typically experience painful vaginal bleeding, abdominal pain, rapid contractions, and uterine tenderness. Placental abruption is classified on clinical symptoms and divided into 4 grades that I'll go over shortly. And management is based on the signs of maternal or fetal distress. So the 4 grades of placental abruption, 0, 1, 2, and 3. Grade 0 is asymptomatic, no fetal or maternal distress, likely just an incidental finding on an ultrasound. Grade 1 is where you might have this mild to moderate vaginal bleeding, uterine tenderness, no fetal or maternal distress. Grade 2 is where you have increased vaginal bleeding, these rapid tetanic contractions where the uterus is just contracting rapidly, doesn't really have time to relax. At this stage, you will likely see fetal distress. And in grade 3 is where you see severe bleeding, fetal and maternal distress, and management will be C-section. So our case, this is a 29-year-old G2P1 at 39.5 who presented in active labor after spontaneous rupture of membranes at home. Past surgical history is pertinent for a C-section in 2019, no cardiac or respiratory history, and at the time of presentation, all her labs and vitals were within normal limits. So the case timeline, this slide's a little bit wordy, but around 7:30 p.m., the first category 2 fetal heart rate tracing was recorded. The nurse midwife checked the patient, who was found to be 5 centimeters dilated, and no vaginal bleeding was noted at the time. About 8 p.m., an epidural was requested. The patient continued in a category 2 fetal heart rate tracing and did report contraction pain as 10 out of 10. Just before 9 p.m., the patient was seated in the seated position for a labor epidural. She reported this constant dull abdominal pain that got up to a 10 out of 10 with contractions, but never had full pain relief even in between contractions. So an epidural was successfully placed at the L4, L5 interspace. After a negative test dose was given, a loading dose of 8 cc's of 0.5% lidocaine was given about 9:18 p.m. Shortly after the initial bolus dose was given, the nurse midwife was called for variable decelerations, and vaginal bleeding was noted on cervical exam at that time. The patient did continue to report persistent abdominal pain rated as 10 out of 10 with contractions, but was experiencing bilateral loss of motor function in the lower extremities, indicating that the epidural was in the right place. So at 9:30 p.m., the decision was made to take the patient to the OR for a category 3 fetal heart rate tracing with recurrent late decelerations, variable decelerations, and fetal bradycardia with heart rate dropping from 130s to the 80s. It lasted for about 90 seconds. So the C-section was performed under general anesthesia. The post-op diagnosis was placental abruption, and both the mother and baby did well and were discharged home in 2 days. So discussion in this, prior to the epidural placement, the patient had this 10 out of 10 pain. It's likely that she had a grade 1 placental abruption that was then precipitated to a grade 2 placental abruption after placement of the labor epidural, leading to increased blood flow to the uterus. As the category 3 fetal heart rate tracing was recorded about 10 minutes after the bolus dose was given, which is consistent with the progression of symptoms that was experienced by the patient. So in regards to the pathophysiology, the theory is that vasodilation leading to maternal blood pooling, along with rupture of maternal vessels in this decidual basalis layer, may have facilitated progression of the placental abruption. So for future directions, you might want to avoid epidurals in patients with known placental abruptions, or give a decreased loading dose or basal rate, or just give the patient other options for pain control, such as nitrous oxide or a romifentanil infusion. And there are my references. Thank you.
Our next abstract is a complex case entitled Supraventricular Tachycardia under Spinal Anesthesia for Repeat Cesarean Section. This will be presented by Dr. Camille Hawkins, who comes from Ohio Health Doctors Hospital, and this will be an in-person presentation. Yay! Thank you for coming.
Hi, I'm Camille Hawkins. I'm a CA2 resident, as discussed, at Ohio Health in Columbus, Ohio. Today's case, we'll be talking about supraventricular tachycardia under spinal anesthesia for a repeat C-section. I have no disclosures or conflicts of interest to discuss. So background, supraventricular tachycardia is an irregular fast heartbeat. Pregnant women are more likely to experience arrhythmias than the general population, just due to the general physiologic increase in blood volume. SVT is also the most common sustained arrhythmia to occur during pregnancy. The most common symptoms of SVT include sweating, shortness of breath, chest pain, syncope, and dizziness. Our case presentation, we had a 31-year-old female, gravida 5, para 2, presented for a scheduled repeat cesarean section with tubal ligation under spinal anesthesia at 39 weeks and 0 days. Her past medical history was positive for prior postpartum hemorrhage, history of blood transfusion, COVID-19 infection during pregnancy, headaches, anxiety, and anemia. Her starting hemoglobin was 9.3. For anesthetic management, intra-procedure, she received a spinal anesthesia with 2 mLs of 0.75% bupivacaine and dextrose with 200 micrograms of morphine at the L3, L4s. She was placed in supine positioning with left uterine displacement and 2 liters of oxygen replaced with standard ASA monitoring. Phenylephrine was used throughout the case for MAT maintenance. During the prep and drape time, she remained stable. Her heart rate, she was tachycardic, low 100s, max 105. However, upon incision, patient began having SVT with heart rate in the 155 range. However, her blood range stayed stable. Systolics range from 87 to 105, diastolics 50 to 74. Her only complaint at that time was palpitation. She denied any shortness of breath or chest pain. Her heart rate, however, was unresponsive to 100 milligrams of esmolol and 10 milligrams of metoprolol. Cessation of SVT was achieved during carotid massage and simultaneous delivery of the fetus. Patient was unable to participate in vagal maneuvers due to the spinal, so it's hard to differentiate whether it was the delivery of the neonate or the carotid massage that helped end the SVT. And just for case management, quantitative blood loss was over 1 liter, urine output 350. Postoperatively, a 12-lead EKG just showed sinus tachycardia, the heart rate of 103. She did not have any further occurrences of arrhythmias during her hospitalization. However, her postpartum course was complicated by acute blood loss anemia, where she received 1 unit of PRBCs. As discussed, her starting hemoglobin was 9.3 and it had dropped to 6.4. Afterwards, she did get a fever of unknown origin. Blood cultures were negative, so it was likely attributed to her blood transfusion and as well as her history of blood transfusions in the past. 1 more EKG was done prior to discharge. It showed normal sinus rhythm after adequate resuscitation. She was discharged home on post-op day 4. And in the last 2 weeks, all she's ever had was routine postpartum management. She has not returned for anything else. Diagnosing new onset SVT, things to look out for: narrow QRS complex less than 0.12 seconds, and a heart rate over 150 beats per minute. Treatment is follow your ACLS algorithm. If a patient is unstable, which means hypotensive, acute heart failure symptoms, go straight to synchronized cardioversion. However, if the patient is stable and you have time, you can trial adenosine, beta blockers, calcium channel blockers, and vagal maneuvers as well. Medications that can be used during pregnancy. During the 2nd and 3rd trimester, you can also use adenosine and verapamil, both which are Class C medications. They haven't been studied, but you can use them. Radiofrequency ablation is also an option. You can use electrical cardioversion at any stage during pregnancy, including labor and delivery. However, there is a small risk for fetal arrhythmia, and so it is recommended that the fetus have a small, there wasn't an exact time frame, but should be monitored for arrhythmias after delivery. Causes of SVT during delivery could be precipitated by use of vasopressors, catecholamine surges, and physiologic increase to cardiac output at term, which are all very common things that we use every day during a C-section. And these are my references. And I'll open the floor for questions. Thank you for having me.
Any questions from the audience?
That was awesome. My question would be, were any of the typical supraventricular tachycardia techniques employed prior to the end of the case, such as carotid massage, etc.?
Yes, we had used esmolol, metoprolol. We did carotid massage. However, that was simultaneously at the time that the neonate was delivered. So it's hard to discern was it the carotid massage or the neonate being delivered, but we did. We just did not do adenosine. We didn't get that far. Thanks.
I have a I'm sorry, go ahead. Sorry.
Just a quick question, the effect of Pitocin on possibility of tachycardias.
Pitocin can cause tachycardia as well as bradycardia. However, at this point, she had not received Pitocin. So in her case, it's unlikely that that was her cause of SVT.
Quick question. So you didn't start with carotid massage. You started with esmolol.
Correct.
I know this was a section, baby would have been delivered relatively quickly, but just be aware, esmolol is controversial during pregnancy as it can cause a prolonged fetal bradycardia that lasts longer than the actual half-life of esmolol, so I would be careful with that. I know you said you use phenylephrine for blood pressure control, but do you use infusion?
No, we did not use an infusion on her. We just used push doses.
So we usually use an infusion, and I think I'm not saying it would have alleviated the possibility of an SVT, but might have been a little bit more beneficial where there weren't boluses.
Okay.
Again, don't know. I've had patients do SVTs. I've had them do atrial fibrillation, and the cardiologist afterward just said, it's catecholamines. So I guess it's catecholamines. I think your references are great, a great learning tool here. Yeah, I think that's about, I think any more questions? Otherwise, I think I'm fresh out of thoughts here. All righty, thank you so much.
Thank you so much.
All right. Our next abstract to be presented is a scientific investigation entitled Virtual Reality as a Novel Approach to Epidural Training. This will be presented by Dr. Sonia Aminat and Dr. Edward Piscatelli from New York Institute College of Osteopathic Medicine. Thank you so much for being here in person.
Alrighty, thank you so much everybody for having us today. My name is Sonia Aminat. This is Edward Piscatelli. We're both fourth-year medical students from NYIT College of Osteopathic Medicine. So as you can see up on the screen, we're going to be presenting today. It's a little bit of a non-traditional scientific investigation project, that's for sure. But it's on the virtual reality as a novel approach to epidural training. Alrighty, so we have no conflicts of interest. So just as an introduction, so virtual reality, as we know, is up and booming, and especially in the field of medicine. It's being used for various educational and learning purposes. But as of right now, there really aren't any virtual reality programs that demonstrate how to administer an epidural. So that's where we came in. And our goal really was to develop a virtual reality program that could be used for educational and learning purposes in any institution, really. So we created the program using the Unity game engine, which is just a program that we use, and it's going to be compatible with the Oculus MetaQuest with the controller. So the use of the controller gives the user the opportunity to participate in haptic feedback and just get a sense of really what they're doing and technique that's being done at hand. So the benefits of virtual reality really is that the portability of the Oculus headset, you can practice just about anywhere and everywhere with zero waste of resources. You can practice as many times as you want. And epidural administration really relies on depth perception and knowledge of anatomy, and this is where VR really comes in. We can fine-tune our senses to really perceive these kind of spaces that you normally wouldn't be able to do in, 2D dimension. So that's where, again, virtual reality comes in. And again, there's certain haptics that we've added to the program that are just going to be able to allow the user to sort of engage and sort of feel the different layers that they are going to be entering as they are going through the experience.
Okay.
Alrighty.
All right. So at least currently right now, so in the next slide, I'm going to show you actually a video and narrate through what we have so far. But right now we're kind of doing a polishing pass and everything. We have all the steps in place. We've kind of just been getting feedback and kind of tuning it based upon that feedback. But really the idea is we want to get this in the hands of some residents, see how it helps them out, whether before actually performing an epidural, and see if it's beneficial for that. In terms of some future consideration, well, I'll go over that after I show you the video. So before I set the scene, I don't know how familiar everyone is with using virtual reality or the Oculus Quest, but it's a standalone headset, so you can use it anywhere, wherever you want. It's just about $300, and then you can take it anywhere. At least in this scene right here. So this is the overall setup. You have it. You start up in a room. You have the patient already positioned for you right in front, and you have all the equipment over to the right, and it's all labeled for you. So what happens, as you can see the text in the wall over there in the front, it kind of goes up as it takes you step by step through the epidural. So you just read the instructions and then perform the following step, and if you do it appropriately, it moves on. So I'm going to try to narrate some of this. So the person's down at the bottom over here, and it's just hands because we don't actually have a player model. But as you can see, first off is just kind of making sure you get those landmarks. Next is actually scrubbing with the chlorhexidine, and it detects to make sure you're actually scrubbing in the correct area. Next is actually physically grabbing and then draping up the patient in the correct area, and then making sure you're rechecking those landmarks at that specific point. Next would then be actually drawing up the lidocaine. So you could actually physically draw up the lidocaine and then actually injecting it inside the back. And you'll get a little bleb to confirm that you actually did that appropriately next. And then you can see right here, we're actually infiltrating that there. Next would be actually inserting the epidural space. Currently, we only have vibrational feedback. We kind of want to have change the vibration based upon the different layers that you're actually going through. So you get that sort of feedback too. And then right here would be actually attaching loss of resistance. And again, you get this vibrational feedback, and once you lose that, that kind of simulates the idea that you've reached the epidural space and you inserted the catheter, correct, or inserted the needle correctly. And then again, so you would insert the catheter next, and then it's just kind of desterilizing it or taking off the drape. And that's it. And you could really just play that as many times as you want so far. So overall, in terms of future considerations and kind of what we want to build upon, when inserting the needle, we want to try to set it up so you actually have a 2D image to see the needle going through the different layers. So you could kind of have that while you're physically doing it. You get the visualization going through the different areas. I don't know if you wanted to say anything more about that.
Yeah, so at this point, it's really just a little bit of fine tuning that we have left and just making it a little bit more aesthetically appealing. Those black walls, we want to make it an actual representation of an OR experience just to get the user to have a perfect feel of the scenario. And then after that, we're hoping to launch it and distribute it to as many institutions as possible for their own individualized use. Thank you.
Good job, guys. Any questions from the audience? I have a question. Certain things like sterility or patients moving, stuff like that, are you able to perform that on that? Can you get the mannequin to move around?
Yeah, you could, literally, it's all like physics-based. So like you actually have to, meaning it has a collider and you actually contact with the patient. So yeah, you could do anything you want. It's just a matter of adding in an animation. You can set up different scenarios too if you wanted. It's really up to what you want to develop.
And you mentioned a little bit, you touched about expense. The Unity game engine and the Oculus Meta handsets and all that, what are you looking at as far as price?
So Unity game engine is free, actually. It only costs money if you were to sell it, like actually monetary value at a certain point. But the Oculus headset, it's about $200 to $300 depending on what you get. And then once you buy that, our application's free, so that's all you need.
All right, any other questions?
My question was along the same line. Can you simulate like red taps or hitting an epidural vein, something like that?
Sorry,
wet taps?
Yep. So that's something that we're actually going to take into consideration. Once we finalize sort of this baseline model that we have, we're going to sort of expand upon certain areas that we might need to troubleshoot, and that being one of them. And another being, well, a patient, this is an ideal patient who's upright, whose BMI seems moderately okay, but in the future we want to sort of, again, create models where we might need to troubleshoot. What if a patient has scoliosis and their spine is not straight? What are we going to do in that case? Or what if we have a patient with a BMI of 57, like we were talking about earlier? So certain things like that, it's definitely on our goal list, and we're hoping to do that in the future.
I also have a question. So no Shark Tank, I guess, huh? Anyway, Once this is up and you teach your residents to use this, any thoughts of doing a comparative study where you have some do without, some do with, and then on actual patients see how they do or how they feel more confident, their success rate at epidural placement, that kind of thing?
Yeah, absolutely. That's one of our ultimate goals. We really want to see what the success rate is, like you mentioned before and after using this virtual reality program. That's essentially the reason why we created it. Speaking of Shark Tank, we'll be at the ASA next month. So we'll see you there. But yes, ultimately that is our goal.
All right, well, great. Thanks so much for a great presentation.
Thank you.
All right, our next abstract to be presented is a complex case presentation entitled Veno-Venous Extracorporeal Membrane Oxygenation for Acute Respiratory Distress Syndrome Secondary to Chlorine Gas Inhalation Injury. This will be presented by Dr. Drew Michael Donnell, who comes from Ohio State University. Thanks for being here in person.
Thank you and good afternoon. As she just stated, my name is Drew Michael Donnell. I'm a CA3 at Ohio State University, presenting this on behalf of Dr. Kyle Jefferson, who many of you know, as he is a fellow of this group. Kyle Jefferson? Or Kyle Dryden. All right, moving on. So for the next slide, I certainly have no disclosures at this point in time. So for some background, acute toxic inhalation is a known clinical emergency which requires timely multidisciplinary intervention. We know that it accounts for greater than 8% of all exposure-related deaths. What we know from looking at NIOSH and National Occupational Exposure Safety data is that more than 1 million Americans yearly are at risk for clinically significant toxic exposures. And looking at data from poison control centers, we know that toxic substance exposures are actually much more likely to occur in the domestic setting. Common toxins include asbestos, phthalates, BPA, formaldehyde, lead, and then also our perifluorinated chemicals. Certainly we know quite a bit about the intensity and lethality of chlorine gas suspensions, as they were often utilized as an agent in World War I. However, they continue to be mass-produced today, as they are internationally produced for both industrial and domicile uses. Now, in the instance of acute chlorine inhalation injury, it's been known that as a sequelae can progress to acute respiratory distress syndrome, and unfortunately, very limited data on this matter, and there are only two case studies to date that look at ARDS and as it advances requiring extracorporeal life support. So in my case, we look at a 46-year-old female with no significant past medical history, BMI of 35, who incurred a gas inhalation injury while she was mixing concentrated chlorine in preparation for her backyard pool. She was intubated in the field by EMS, where she was found to be in a state of severe acute hypoxic respiratory failure. Now, she was admitted to outside hospital, where her workup was significant for a pH of 7.2, where she was emergently cannulated with a right femoral and right internal jugular VV ECMO system. She was then subsequently transferred to our institution, where she, in addition to lung protective ventilation strategies, was also started on inhaled epoprostenol, a norepinephrine infusion. Of note, I performed a bedside TTE, which is significant for biventricular dysfunction, right worse than left. A little bit of just graphics here. You can see that on the right side you have bilateral opacification, certainly right worse than left, and that is at the first day at which she was admitted. Fortunately for her, more than anything, this talk is sort of a proof of concept. She recovered in an extremely fast fashion. At day 7, you can see her X-ray was markedly improved. Certainly with this right side, which was the worst at the beginning, is markedly cleared. Then at day 11, once she had become PCU care and I stopped taking care of her, I, in happenstance, saw her wheeling by as she left the ICU on room air and actually took a few steps herself. Just a quick discussion. This case study shows successful utilization of VV ECMO treating ARDS. As I mentioned, there's very limited work in this area, particularly for chlorine gas inhalation. Certainly are no randomized controlled trials to evaluate various interventions. Sort of some of the best information I can find right now is this paper from White and Martin, where it looks at mechanisms of injury. First off, we know there's three primary mechanisms. First, with the chlorine gas, it can become hydrated and then forms hypochlorous acid. Additionally, you have epithelial disruption, formation of myeloperoxidase, and then constriction of smooth muscle, which then affects airway functioning and implied airway hyperreactivity. Essentially, this is just, as I said, a proof of concept and hopefully provides additional motivation for work in this area. Here are my references. And again, I know at the beginning I said Kyle Jefferson, but sorry, Kyle Dryden was my mentor on the matter.
Okay, thank you so much. Do we have questions from the audience? Go ahead.
Were there other things that were tried before patients put on ECMO? I mean, or is that like the go-to for that?
Yeah, I think that's a great question. In this patient, when she first arrived at the hospital, she was already intubated. The first pH was 7.18, next one was 7.2, so a little bit of improvement. I can't speak a ton for the decision-making at the outside hospital, but it appears that the patient was emergently placed on VV ECMO. They also initiated dexamethasone and broad-spectrum antibiotics, but it's sort of, essentially it all happened simultaneously, and she was very quickly transferred to our institution.
Other questions from the audience? I have a concern. So what do we do about people that are competitive swimmers and are in chlorinated swimming pools for hours and hours every day? Do we have to be concerned about that?
So I think, if I had some colleagues from NIOSH, I would refer that question to them. What I can tell you is, looking at the literature, one of the case studies was actually it was an 8-year-old girl in Sri Lanka, and she developed ARDS just from exposure to a regular old swimming pool. So there are people that are at higher risk. Now, I can almost guarantee, and based on the studies, that chlorine was in much higher concentration than recommended in that swimming pool, and it was a large public swimming pool. So I think if we control concentrations, there's much hope that we can continue swimming and sending people to the Olympics.
Thank you so much for a fascinating presentation.
Thank you.
Okay, our last presentation is a complex case entitled A Case of Horner's Syndrome in the Labor Epidural Patient. This will be presented by Dr. Nicholas Lefevre, who comes from UPMC Lidditz. Thanks for presenting in person.
All right, hello everyone. Okay. So this is a case I had about 1.5 years ago, Horner's syndrome in a labor epidural patient. I'm a CA3 at UPMC Lidditz, and Dr. Walters is the anesthesiologist overseeing this. Again, I have no financial interest affiliation concerning the material in this presentation. Okay, so just a brief introduction to Horner's syndrome. There are about 200,000 cases a year in the United States. It's believed to be caused by cephalid spread of local anesthetic in the epidural space. This is at about C8 to T1. where the second order neuron is just going into the stellate ganglion at that level, and that's where they believe the effect is being caused. There's a triad we all know of: ptosis, meiosis, and anhidrosis. And then you can have other symptoms as well, such as anophthalmosis, which you really see because of the ptosis. And you can get flushing and hyperemia of that eye as well. The mean onset time is 25 minutes from the initial start of an epidural anesthetic to 215 minutes resolution. And then just briefly, any unresolved cases, of course, you want to further investigate, whether it's with neurology or getting an MRI. In the extremely unlikely, circumstance that it's not the epidural causing it, and there's another exacerbating factor there. Just a real quick table here. You can see that the incidence of Horner's syndrome is pretty similar in a lumbar epidural and a thoracic epidural. And we'll go into some of those reasons why that is, but it just goes to show you that despite being a higher level block, they still can achieve the same ascending level of a block, which can be concerning and just something to think about when you're doing epidurals. And another component is that most of these cases of Horner's syndrome do go unnoticed, so just keep an eye on that as well. Okay, now for the actual case. So we have a 30-year-old female, 102 kilograms, 36 weeks gestational age, unremarkable past medical history, just admitted for spontaneous rupture of membranes, presenting for labor epidural at 4 centimeters dilation. She was mildly anemic, and on one of her notes, she did have some tachysystole as well. And that's pretty much it for as far as the initial case. She was admitted. She was giving Pitocin, but again, they discontinued that because of the uterine tachysystole. And eventually, we were called for an epidural placement. I placed that initial epidural, L4, L5, just 5 mLs of 0.5% lidocaine. Just as my bolus, patient was feeling relief. Not soon thereafter, 30 minutes, patient's in severe pain again. She's used her demand bolus. She's feeling cold at all levels, and she was given a larger bolus by another one of the residents about a half hour later. 10 mLs, 0.5% lidocaine. Continuing on, wasn't working too well, or believed to not be working too well, so anesthesiologist came in, repeat the epidural at a higher level, patient again getting mild relief. And then 30 minutes later, the patient's husband noted the left-sided ptosis, and at that point, everything was turned off. I didn't make a mention of that, but epidural infusion was stopped. Symptoms resolved, and then a few hours later, she had a healthy baby girl. So just a couple interesting learning points about factors contributing to the spread of local anesthesia, especially in this population, pregnant patients. They have an increased intra-abdominal pressure from the gravid uterus. They have decreased compliance of their epidural space because that venous plexus is engorged within that epidural space. In our case, the uterine tachysystole probably played a huge part as well. She had some abnormal pain for, obviously, I'm not downplaying the pregnancy, but she was having quite a bit of pain, quite a bit of sensitivity pain at all times. Patients have an increased progesterone level at this point in pregnancy, about 20 times their pre-pregnancy values, and that goes along with an increased sensitivity to local anesthetic because of that progesterone level. And another case for frequent epidural boluses, you increase that volume, and then as we all know, that can give you a higher block with an increased volume concentration in the epidural space, and that happened here as well, so sorry about that. That's it.
Any questions from the audience? Dr. Griffith?
was wondering, among the factors listed, you didn't mention intradural, epidural. Is that a consideration?
Oh, what? I'm sorry.
Intradural.
Oh, yeah. Yeah, I mean, that would definitely be a consideration. You know, for her, we didn't see any of the symptoms of that. No hypotension. She was able to move, you know, her lower extremities. And I think one of the interesting things was that she still had ice at levels, and multiple providers came in, and she was still having all of this pain, even though it's such a high block and it must be in there. That's definitely a consideration for that as well. Thank you.
Yeah, I too was going to say something about what do you think it was subdural, although those are patchy, but usually you get a little more something in terms of pain relief than that. And due to septations in the epidural space, we've seen this several times at our institution. But my question for you is, would you avoid an epidural in a patient the next time who had a Horner syndrome within her first epidural, or how would you counsel her?
I think I would take a look at the clinical picture again with that patient. Is she having considerable pain with these contractions, potentially pushing up the volume of the epidural? I would probably bolus less, and I would probably make sure everyone in the department's informed that, you know, what's going on, and not to go in there and give boluses and start new epidurals and all those kind of things. So, but I think it would be something that I would not, something I would still consider doing. I would just be more careful while managing it.
And maybe tell the patient what you thought, and it might happen again, but it's not anything to really worry about. Right. Yeah. Okay. In the interest of time, let's give a big hand for this presentation.
Thank you.